Hi, good afternoon, everyone. Just a few reminders before we get started to please keep your lines muted. And you can just see that we have a little information at the bottom here where it tells you just how to mute and unmute your line, how you can turn on and off your video options if you need to, and also if you want to ask any questions or put anything in the chat box, there's a little icon at the bottom that says chat that you can just click on. And to raise your hand also, you can just click on the reactions button and you can raise your hand. It's just another reminder, if you would like to ask any questions, we ask you to kindly use the chat box, and you can use all the participants option. And also just another note, if you didn't know already, this meeting will be recorded for internal purposes only. Thanks, Lindsay.
Thanks so much, Glenys. As we begin today's session and begin to think about transitions in care and services, it is important to situate ourselves on the land in which we reside on. At RNAO, we recognize that our work and the work of our members takes place on traditional Indigenous territories across Ontario. We also wish to acknowledge that the office of the RNAO is located on the traditional and unceded territory of the Huron-Wendat, Haudenosaunee, and the territory of the Mississaugas of the Credit. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, which is an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We also recognize that you, the participants of today's session, are located on other traditional lands across Ontario, and many of you from outside of Ontario and internationally as well. Today, this land is still the home to many First Nations, Inuit, and Métis people from across Turtle Island, and we are grateful to have the opportunity to work on this territory. By personally making a land acknowledgement, you are taking part in an act of reconciliation, honoring the land and Indigenous heritage, which dates back over 10,000 years. We encourage you to learn about the land you reside on and the treaties that are attached to it. Land acknowledgements are an act of reconciliation, and we must all do our part. This past June, RNAO released the second edition Transitions in Care and Services Best Practice Guideline, and it is now available for free on our website. As we begin today's webinar, we invite you to download the guideline by scanning the QR code using the camera on your phone. We will also post the link in the chat box. Throughout today's presentation, we've also posted the pages in the guideline that you can refer to for further information. We are delighted to have members of the expert panel who played a crucial role in the development of this guideline present during today's session. This includes the co-chairs, Dr. Rhonda Crocker-Ellicott, President and Chief Executive Officer of Thunder Bay Regional Health Sciences Center and Chief Executive Officer of Thunder Bay Regional Health Research Institute, and Shirley Sharkey, former President and CEO of SE Health. We are also delighted to be joined by Judy Smith, who is the co-chair of the Patient, Client, and Caregiver Partnership Council with Southlake Community Ontario Health Team, as well as Chantel Antone, who is the Senior Director of the Office of Inclusion and Social Accountability Indigenous Health at London Health Sciences Centre. Welcome, Rhonda, Shirley, Judy, and Chantel. We are so glad to have you on the line with us today. In addition to hearing from expert panel members during today's session, you will also hear from members of our RNAO team who are involved in supporting the development, implementation, and evaluation of this guideline. As mentioned earlier, my name is Lindsay Howlett, and I am a Senior Manager of Guideline Development and Research at RNAO. I am also joined today by my colleagues Catherine Wallace and Christina Medeiros, who will be speaking today about implementation and evaluation of the Transitions in Care and Services Best Practice Guideline. I'm now going to turn it over to Rhonda to share about the objectives of today's session.
Thank you very much, Lindsay, and good afternoon and welcome everyone, and thank you for joining us this afternoon. So to start out, I just wanted to talk about what we're planning on doing this afternoon. So the first half of the webinar, we're going to be talking about the complexities of transitions in care and the value of using this BPG to improve safety and the quality of transitions. We're also going to talk a little bit about the BPG purpose and scope, the guideline development process, what we went through, and good practice statements and recommendations that were included in the guideline. Then we're going to take a short break, and our RNAO team will discuss next steps for kickstarting implementation and evaluation of the BPG in various practice settings. And then there'll be opportunity to ask questions through the process and at the end of the webinar. So now I'm going to hand it back to Lindsay to start off the presentation by sharing more about the RNAO. So thank you very much, Lindsay. Back to you.
Thanks, Rhonda. So before we begin, we would like to give a bit of background on the Registered Nurses Association of Ontario, or RNAO. RNAO is the professional association of registered nurses, nurse practitioners, and nursing students in Ontario, Canada. We are the strong, credible voice that leads the nursing profession to influence and promote healthy public policy and clinical excellence. A signature program of RNAO is our International Affairs and Best Practices Guideline Center, which houses our Best Practice Guideline program. RNAO BPGs are actively implemented across Canada as well as internationally through partnership with our Best Practice Spotlight organizations, which we refer to as BPSOs. The health policy program is another core pillar of RNAO as well. The RNAO BPG program was launched in 1999 and it is funded by the Government of Ontario. The purpose is to develop, disseminate, and actively support the uptake and sustainability of evidence-based clinical healthy work environment and system-level BPGs, and to evaluate their impact on patient organizational and health system outcomes. We currently have developed over 50 best practice guidelines, and this continues to grow, and a variety of implementation toolkits to support implementation processes, which you can see at the bottom of this slide as well. Here on this slide, you'll see RNAO's integrated BPG model that includes 3 integrated pillars of guideline development, guideline implementation, dissemination and sustainability, and guideline monitoring and evaluation. These pillars inform one another, and they work in sync to improve outcomes for people who are receiving care and providers and organizations. So during this webinar, we will focus on all 3 pillars as they relate to developing, implementing, and evaluating the Transitions in Care and Services 2nd edition Best Practice Guideline. As mentioned before, we also want to highlight the Best Practice Spotlight organizations who enter into formal partnerships to implement RNAO BPGs in Canada and internationally. Over the last 2 decades, the BPSO program has spread to include over 1,000 BPSOs globally. The Transitions in Care and Services Best Practice Guideline will be a foundational guideline for BPSOs to implement. There are various models of BPSOs, including the BPSO model for Ontario health teams. OHTs are groups of providers and organizations working together to live a continuum of coordinated care to an attributed population in Ontario. This 2nd edition Best Practice Guideline has been developed in consultation with Best Practice Spotlight organization Ontario health teams to ensure that their recommendations support integrated care across sectors. I am now going to pass it over to Shirley.
Thanks very much, Lindsay. And I guess it's good afternoon, everyone, and welcome. Before going on, we thought it would be important to outline how transitions in care are defined in this particular best practice guideline. A transition in care occurs when a person moves from one setting or sector where care or services are provided to another setting or sector, including but not limited to primary care, home and community care, mental health and substance use, health settings, acute care, rehabilitation, long-term care, correctional facilities, and shelters. So as you can see, we've tried to incorporate the broad array of areas and settings. Examples include transitions from home to long-term care or hospital to hospice. A transition can also occur within the same organization, such as when a patient moves from the intensive care unit to a general ward in the hospital. Transitions in care can also be nonlinear. For example, a person can transition home after a lengthy hospital stay only to be readmitted to the hospital after a few days. Some transitions in care also represent major life events. This can be especially true for persons transitioning, for example, to a long-term care facility, where this will become their permanent home and residence. Transitions in care require thoughtful attention and compassion from health and social service providers, and a strong emphasis on safety. Within this guideline, the term transition has been used intentionally instead of the word discharge wherever possible. This is because within an integrated system, people are cared for by various health and social service providers within the system. They are never truly discharged from a health or social service organization, but instead transition from one setting to another. When we think of transitions in care, we need to root our understanding in the experience of people who are receiving care. So therefore, as a way of starting today's webinar, We would like to hear from Judy Smith, who's co-chair of the Patient Client Caregiver Partnership Council at South Lake Community Ontario Health Team. How is that for a bundle of words, Judy?
Thank you very much, Shirley. You did very well. And thank you and welcome to everyone. And thank you to the RNAO for engaging with me to be part of this process. I have retired from the healthcare sector, so I have a little bit of knowledge. I've been with the Ontario Health Team South Lake Community since its inception, in mainly the role of a caregiver to a wonderful mother-in-law who's turning 99 next week. She unfortunately had a medical incident in a retirement home at the time and ended up in hospital with 2 broken ankles, ended up then going to a reactivation center and eventually home on what was a blended bundled care model where one agency was managing those transitions. What was unique at the time and what is unique moving forward with the Ontario Health Team model is that caregivers and patients are considered partners in care. And also, as we're moving forward with that integrated model, it's important that our voices as patients and caregivers are at the table with co-design. So that was my initial role, was to be that of a caregiver. While the process of developing this guideline went on, I ended up in the role of a patient and had the opportunity to watch my husband take over the role of the caregiver, not only of his mother-in-law, but then with me. And just want to share a little story about the challenges of being a caregiver and a patient, and a success, what a good transition looked like for me and what an excellent transition was. People don't understand at the time that transitions are done, if the caregiver isn't involved up front, there are going to be gaps in care. There are going to be follow through. And the caregiver person, who is often an unpaid family member, not only now dealing with challenges within their own life situation, but taking on that role. So I was admitted to hospital, discharged from hospital, and the day before discharge met with the unit-based pharmacist who reviewed all my medications, handed me the piece of paper telling me how to deal with it, and said he'd faxed it off to the pharmacy for me. Went home late on a Friday night, did not have any take-home medications to get me through the night until my husband could pick up the prescriptions the next day. And I can still see the look of panic on my husband's face when he walked home with 2 grocery bags full of medications. His concern at that point was I needed some insulin. My concern was I needed something for pain, and these bottles and boxes just rolling all over the kitchen table. What we very quickly realized was I had the cartridges for my insulin, but I didn't have any way to administer it. So it meant that he needed to go back to the pharmacy. So far, we had heard from nobody that was going to be coming into the house to help support and provide care. Second transition was a few months later from another hospital. Again, the unit-based pharmacist came in, brought in all the information with him, went through the whole prescription with me, talked about, what was changed, what was different, and then said that he had faxed it to my pharmacy, which was great. And said he had also faxed it to the outpatient pharmacy of the hospital, who was preparing 2-week pill packages for me to take home to ensure that I had all of the medications that I needed. And not to worry that the hospital would send me a bill for the prescription fee. What we talked about when we were talking about the transitions, and as we go through the recommendations, you will see that there's a recommendation that after the transition, a follow-up be done to make sure that transition was safe and smooth and an opportunity to answer questions. Went home, my husband said, do I need to go to the drugstores? That panic came back over his face. I said, no, I have medications with me. The next day, as promised, the pharmacist called to do a follow-up phone call. Did I have anything? Did I need anything? Did I have any questions? So it was a much smoother transition. Both of them were good. but that second transition worked better. Going back to my mother-in-law's situation very quickly before I hand it back to Shirley, was when they did the midpoint survey in her bundled care, was the staff actually asked me as a caregiver, how was I managing? Often the focus is on the patient or client and not the caregiver. Did I have any needs? And that's another important thing. We need to support our caregivers moving forward. So those are a couple of examples of the stress of being a caregiver and also how we can support them moving forward. So thank you, Shirley, and I'll hand it back to you.
Thanks very much, Judy. And I did have the wonderful opportunity to meet your mother-in-law during that transition, as you recall. And
Yes, I do.
It was just a delight to see when things are smooth and work well for everyone. And that's certainly what we hope with the continuation of this best practice guideline.
He still talks about that meeting.
The purpose of this guideline is to provide evidence-based recommendations, not only for nurses, but for all members of the interprofessional team, organizations, and the health system to support safe and effective transitions in care for both the pediatric and adult persons, but even more importantly, their support network. As I mentioned previously, this BPG focuses on transitions in a very broad way between many settings, from primary care all the way through to shelters. The BPG recognizes that persons and their support network who are encountering a transition in care are in fact experts in their health and in their decision-making. The term support network is used to refer to individuals whom a person identifies as significant in their care and in their life. It can include individuals who are related and or those who have a close bond. There are many populations that are particularly vulnerable and experience barriers to care during care transitions, and pre-existing social economic disparities further complicate access and health inequities. This BPG is developed and has been developed to ensure that the recommendations support integrated care across settings and sectors, and that they ultimately improve health outcomes and health equity for persons encountering transitions in care and services. I'll now pass it back to Lindsay to share more about the development of the guidelines.
Thank you, Shirley, so much. You'll remember that the RNAO integrated BPG model contained 3 pillars, and the pillar at the top was the BPG development pillar. And you'll see that pillar on this slide here. Our guideline development process consists of 6 steps that are outlined. First, the topic was chosen and an interprofessional panel of experts was convened. So the panel was very involved in developing the purpose and scope of the guideline, as well as determining the key recommendation areas the guideline would focus on. And you'll hear more about the expert panel in the coming slides. With input from the expert panel, systematic reviews were designed and conducted by the RNAO team, and peer-reviewed literature was reviewed and screened. These systematic reviews then inform the basis for the guideline recommendations, and we'll also speak to this later on, that there are also good practice statements that are included in this guideline. Then the guideline was drafted and reviewed by external reviewers within Canada as well as internationally to enhance the quality of the guideline. And we had over 100 stakeholder reviewers review this guideline, which only further enhanced the rigor of it. Discussion groups were also held with representatives from Best Practice Spotlight Ontario Health Teams, Organization Ontario Health Teams, furthermore at this stage. Finally, our guidelines, after they are published, will be updated as well, and we'll aim to commit to a 5-year revision cycle for this guideline. I want to highlight on this screen where it says grade here, and it's important to note that when we develop our guidelines, we use the grading of recommendations, assessment, development, and evaluation grade methods to support our rigorous guideline development process. And grade is in line with international standards, and it's used by other large organizations such as the World Health Organization. Rhonda is now going to talk a bit more about the expert panel.
Thank you, Lindsay. So this guideline could certainly not have been created without the expert panel, who contributed so much from their knowledge and expertise to develop this important resource. The expert panel included persons with lived experience and was interprofessional in composition. It comprised individuals with experience in clinical practice, education, research, and policy across a range of health and social services organizations, academic institutions, practice areas, and sectors. All of these experts share their insights on supporting and caring for persons and their support network when encountering transitions within and across settings. So on this slide, you see the names of the expert panels and many of those who are participating on the call today. So thank you all. And this panel played a key role in determining the best practice guidelines purpose, its scope, and recommendation questions. And they provided incredibly valuable feedback at various stages throughout the guideline development process on the draft BPG, the indicators, and implementation tips and supporting resources. So as part of the guideline development process, the draft guideline was also reviewed by end users. So this was an opportunity to ensure that we were validating across with external users from within Canada and internationally, which further enhanced the rigor of the guidelines, and their names can be found within the guidelines. Next, as mentioned earlier, BPSO-OHTs also played a key role in the development of the guideline and were consulted to ensure that the recommendations actually supported integrated care across sectors. The expert panel for the BPG included health and social services providers and persons with lived experience from BPSO-OHTs. And BPSO-OHTs also provided feedback on the BPG during the stakeholder review stage. And finally, before we move forward, I would also like to acknowledge the entire team at RNAO. They were instrumental in involving and bringing this guideline to life. We have their names outlined on this slide, and really just want to give a huge shout out to the entire RNAO team. Just amazing individuals that really provided the backbone to this whole development process. So thank you all, and I'll pass it back to you, Lindsay.
Thank you so much, Rhonda and Shirley. And it was a sincere pleasure to work with the expert panel in the development of this guideline, and for your leadership, Rhonda and Shirley, as co-chairs. As mentioned before, RNAO uses the GRADE methodology when developing our guidelines, which provides a really transparent framework and a systematic approach for developing the guideline. You'll notice that this guideline contains both good practice statements and recommendations, and we'll walk you through the difference between both statements. But what is really important to remember is that they are both action-oriented statements that are based on evidence, and they make the guideline something that can be implemented. They follow the same process for implementation. Good practice statements are actions that must be done in practice. They may be seen as common sense actions, but they are not always being done. There might be gaps in them happening, and hence why we need to reinforce them in the guideline. We have high certainty that the benefits outweigh the harms, and a systematic review is not needed to determine this. In addition, researchers may no longer be conducting studies on the topic because the benefits are so well known, or the alternative to the action may be unethical, so it would not make sense to study it. Good practice statements don't receive a rating of strong or conditional, but they can be interpreted as strong recommendations. An example of a good practice statement would be conducting an assessment before carrying out an intervention, because we know that the benefits of this practice of conducting an assessment would far outweigh the harms. Recommendations, as seen on the right-hand side of the slide, are also action-oriented statements, but they're developed based on evidence from a systematic review. They answer a research question about whether an action or intervention should or should not be done, and they are determined to be either strong or conditional, which we'll speak further to in the following slide, by looking at the benefits and harms of the action, how certain we are in the evidence, values and preferences, and the impact on health equity. Again, what is really important to remember, though, is that they are both action-oriented statements that reflect best practices and should follow the same process for implementation. What you see on this slide here are the considerations used to determine if a recommendation should be strong or conditional. The most important factor to highlight, though, and to consider is the certainty of the evidence. If the research shows benefits from the action, but our certainty in the evidence is low or very low based on maybe some limitations in the studies, then a conditional recommendation is warranted. However, our certainty in the evidence is moderate or strong, it would lead to a strong recommendation. It could lead to a strong recommendation. In addition, in order for a recommendation to be strong, the benefits would far outweigh the harms of the recommended practice, and most people would really benefit from it. For a conditional recommendation, the benefits would probably outweigh the harms of the recommended practice. And there's also a need to take into consideration a bit more closely a person's values and preferences for the recommended action. Some people may not want to receive the intervention. I'm getting a little bit of feedback, and so I think there might be somebody who's unmuted. Glynis, if you could maybe just take an eye on that, that would be great. Take a look. Thanks. And now what you see on this slide is a simplified PRISMA flowchart that indicates the rigorous process for the systematic reviews and that the RNAO guideline team conducted for the recommendation questions. Our systematic reviews were aided with the help of a health science librarian. Searches were conducted in 2021 and then updated again in 2023. To answer the questions that inform the recommendations, we screened over 30,000 articles. Of these, 161 full texts were examined for relevance, and finally 23 were included. Each of the included studies was also quality appraised using appropriate validated tools. And you can refer to the Appendix C for more information about guideline development methods. Now, before handing it back over to our co-chairs to walk us through the recommendations and good practice statements, I just want to provide an overview of how to read the components of the recommendations within the guideline. And you'll see an example here from recommendation 5.1 on the slide. So for each recommendation, you'll see the recommendation box, which outlines the recommendation statement, as well as the strength of the recommendation and then the certainty of the evidence as well. The recommendation box is followed by a discussion of evidence for each recommendation, and it includes 6 components. So the first one is benefits and harms, and really in simple terms, this describes desirable and undesirable outcomes reported in the literature when the recommended practice is implemented. The second component is values and preference. It highlights preferences for a recommendation and the values placed on health outcomes from the perspective of people who are receiving care. Third component, health equity, highlights the impact that the recommendation will have on health equity for different population settings and potential barriers to implementing the recommended practice as well in particular settings. The fourth component, expert panel justification of recommendation, provides a rationale for the strength of the recommendation. And then following the panel justification, you'll see a fifth component where it says implementation tips. And this really describes the how, who, where, what, when related to implementing a recommendation or good practice statement. And this information can come from the evidence as well as from the expert panel. And the final sixth component of the discussion of evidence is the supporting resources, and it includes relevant resources such as websites, toolkits, etc., related to the recommendation to help you implement it. I'm now going to pass it over to Shirley, who will begin to walk us through the good practice statements and recommendations.
Great. Thanks very much, Lindsay. And I was having a panic attack because I thought I didn't have all the pieces of paper I need. I think I have them, so I'll take a deep breath and calm down. There are 5 good practice statements and 3 recommendations that fall into 5 broad categories in this best practice guideline. The summary of the recommendations and good practice statements chart can also be found on pages 12 and 13. And there's also a summary document on RNAO's website that outlines how the first edition guidelines compares with the second edition guideline and where content from the first edition guideline can be found. So now I'm going to move into the good practice statements. And the first one is collaborations with persons and their support network. Certainly reads actively collaborating with persons when developing a care plan and identifying their goals, wishes, and preferences. And this is a standard of professional practice. Not collaborating with them would in essence be unethical. This, in fact, is an overarching statement that is foundational to implementing all other recommendations and good practice statements. When conducting an assessment during a transition plan, which we know is so important, conducting medication reconciliation, etc., this needs to be done in collaboration with the person receiving care, but also their support network, should they consent to involving them. Evidence shows that far too often, caregivers and other members of a person's support network are not involved in the planning process. And we can see from Judy's story how there are outcomes that are positive at times, if you include, and if you don't, how they are more challenging for the individual and their care. The benefits of collaborating with people and their support network when planning for a transition are clear. When people receive information they can understand and act upon, they are better equipped to manage their needs following a transition in care. Lack of collaboration can result in inappropriate care plans and anxiety for people receiving care, and certainly for their support network. To achieve the best outcomes, it is important to use a shared decision-making process. This is one that involves determining and integrating a person's wishes and preferences into the decision-making. The implementation tips highlight practical tips, such as open-ended questions that providers can ask to ensure that the person's voice and concerns are heard, and tips for building trust and also engagement. We're on to now the second good practice statement, assessing care needs and readiness for a transition. It is good practice that health and social service providers assess with persons and their support network their care needs and readiness for a transition. Conducting an initial assessment of a person before developing a plan of care or any intervention, as we know, is a standard of professional practice. Assessing readiness involves assessing medical stability, functional ability to manage self-care, having the knowledge, skills, confidence, and supports necessary to manage the transition, and to cope with common challenges that may arise. Assessing readiness is a central component of transitional planning. The evidence shows that low levels of readiness can lead to feeling unprepared, difficulty coping, and a higher likelihood of hospital readmission. Assessments also help identify the type of care and assistance required following a transition, and also barriers that may prevent a smooth transition. It is imperative that providers seek to understand the social determinants of health that affect the person when conducting assessments, such as income, housing, social inclusion. So it's all about their life, not just about their healthcare needs. While assessments are critical to prepare for a transition, the expert panel highlighted that providers should avoid repeating assessments unnecessarily. We hear a lot about this from clients and families as they go through transition. It can be very frustrating for people to repeat their story multiple times, to repeat how many times their date of birth is, to repeat how many admissions they've had. To avoid repeating assessments unnecessarily, providers should review previous assessments and build on them, highlighting similarities and also changes. The implementation tips also now provide further details from the expert panel on who should perform assessments, what should be assessed, when, where, and how the assessment should take place, and what health equity concerns providers should be mindful of when conducting an assessment. The next good practice is interprofessional collaboration. Again, it's good practice that members of the interprofessional team collaborate to develop a transition plan that supports the unique needs of persons and their support network. Collaborating with other members of the healthcare team is a standard of professional practice. As such, collaborating with the interprofessional team to develop a transition plan that supports the unique needs of persons and their support network is good clinical practice. Transition plans promote continuity of care, which we know is so important, and ensure necessary services, supports, and resources have been arranged as people move from one setting or one sector to another. When providers collaborate to develop a transition plan and contribute their combined skills and knowledge versus working in isolation, a more comprehensive transition plan can certainly be developed. It can be especially beneficial to have health and social service providers from different disciplines contribute to developing the transition plan, as their combined skills and knowledge can help ensure the person's needs are well addressed. Now, interprofessional collaboration. The expert panel suggests that health and social service organizations collaborate to implement a formal interprofessional cross-sectorial approach to support persons encountering transitions in care. For the purpose of this guideline, a formal interprofessional cross-sectorial approach is defined as a collaborative approach where two or more health or social service providers from different disciplines and in different sectors work together in a formal way to ensure that persons and their support network experience a safe transition in care. And we know very often we sometimes work in isolation, and that important cross-sectorial collaboration doesn't take place. The studies included from the systematic review looked at cross-sectorial collaboration among providers who were supporting adults transitioning from hospital to home or from hospital to a rehabilitation facility when compared to standard care. The types of formal interprofessional cross-sectorial approaches varied across studies. In one study, providers in hospitals and a rehab facility met by video conferencing to discuss the plan of care for persons experiencing a transition. Further details about the types of interprofessional cross-sectorial approaches studied can be found in the implementation tips of this guideline. The evidence suggests that using formal interprofessional cross-sectorial approaches to support persons during transitions in care may increase follow-up visits with a health or social service provider, increase patient satisfaction, improve quality of life, and reduce hospital readmissions within 30 days. So we know how critically important this is. However, the evidence was very uncertain due to limitations in the study from the systematic review. In terms of the impact on health equity, the expert panel emphasized that formal interprofessional cross-sectorial approaches should be the norm and not the exception during transitions in care, especially from underserved populations or those with complex needs. If communication breaks down and information is not accurately shared during transitions across settings, as we know, it may result in significant harm for these populations in particular. I'll now pass it over to Rhonda to walk us through Good Practice Statement 4.
Thank you very much, Shirley. So I have the pleasure of walking you through the final two good practice statements and two of the recommendations. So I'm going to start with review of medication history. So in order to ensure medication safety, it is good practice for healthcare providers to conduct the following in collaboration with the person encountering a transition and their support network. Obtain a best possible medication history and perform medication reconciliation at all transition points. So ensuring medication safety is a professional standard of practice. So during transitions of care, medications are frequently stopped, adjusted, or newly prescribed. So communication and care processes can obviously break down at various points during a transition in care, resulting in unintended medication errors or discrepancies, including the omission of medication, prescribing errors, or failures to communicate changes in medication, just like we heard Judy's story around her medication examples when she was discharged. So a considerable portion of medication discrepancies result in medication-related harm. So obtaining a best possible medication history and conducting medication reconciliation can help improve medication safety during transitions in care. And obtaining a best possible medication history includes interviewing the person or member of their support network and verifying the medication history with at least one other reliable source of information to gather a complete and accurate list of medications used at the time of transition. Medication reconciliation involves comparing the best possible medication history with prescribed medications, identifying and resolving any discrepancies, documenting changes, and updating the medication list. Now, the next good practice statement is around navigation support. So it is good practice for health and social services providers to provide persons and their support network with information and support to manage their needs during and after transitions in care. So during transitions in care, many important instructions and details are communicated to people and their support network. So it's vitally important that all people who are experiencing a transition in care receive information and support to manage their needs during and after transitions in care. So this includes providing individualized health education and coaching to promote self-management, scheduling appointments, making referrals, or providing guidance about services or community resources, and helping persons to identify and respond to complications or warning signs. So when people receive this information, they're provided with a means to understand the benefits and the harms and the outcome of potential treatments. It empowers them in their care and increases their self-efficacy navigating the healthcare system. So while the previous good practice statement focuses on providing information and support to all people during transitions in care, this guideline also recognizes that people with complex needs may require additional support to help them navigate the system, such as routine follow-up from a health or social services provider who can assess and address barriers to care and attend to the evolving care needs. So the recommendation here reads, the expert panel suggests that navigation support be provided by health or social service providers for persons with complex care needs encountering a transition in care. And this support includes regular follow-up by the provider or providers to assess and respond to the person's current and evolving health and social care needs. The strength of the recommendation is conditional and the certainty of the evidence of effects is very low. So for the purpose of the guideline, navigation support refers to individualized and coordinated support provided by health or social services providers to help people overcome challenges related to navigating health and social system during transitions in care. And in this BPG, navigation support involves regular follow-up by a health or social services provider who attends to a person's individual needs and connects them with the right services and supports. So throughout the studies, navigation support was provided by both regulated health and social services providers, so nurses, social workers, for example, and non-regulated health and social services providers in the form of peer workers with lived experience or transition coaches. Regular check-ins allowed health and social services providers to determine if the person's circumstances, needs, or goals had evolved, and whether services provided met the person's needs and whether new services or supports were required. So contact was mainly provided through in-person visits or phone calls, and the length of visits ranged from 1 month to 1 year. The evidence suggests that providing navigation support to persons with complex healthcare needs during a transition may increase follow-up visits and reduce hospital readmissions within 30 days of transition, which is so important, and may increase patient satisfaction. However, there were some inconsistencies in the results, and the evidence was uncertain due to limitations in the study. No harms were reported in the studies, and in studies, persons highly valued the navigation support they received from health and social services providers as it bridged inpatient and outpatient services, relieved anxiety, and promoted continuity of care during very difficult and challenging transition periods. So the next recommendation is the expert panel suggests that peer workers with lived experience offer support to persons with mental health needs who are encountering a transition in care. So for purposes of this guideline, peer workers with lived experience are non-regulated providers that have lived experience through experiences similar to those of their peers. So a mental health challenge or illness, for example. And these individuals are trained to support others on their journey by providing a consistent presence along with emotional and practical support. The included studies focused on either peer support provided to persons following a transition from hospital or peer support to persons following transitions from mental health crisis resolution team. The types of support provided by peer workers varied across the evidence. Support included assessing needs prior to a transition, linking persons with community-based supports and resources, or sharing coping strategies. The evidence suggests that offering peer support may increase patient satisfaction and improve the quality of life. However, the evidence is uncertain due to limitations in the studies from a systematic review. No harms were reported in the studies, and participants highly valued the support from peer workers and noted that peer workers acted as a role model during vulnerable periods and offered hope for the future. This brings us to the end of our summary of recommendations and good practice statements. And the second section of today's webinar will focus on how to begin implementing these recommendations and good practice statements and evaluating this guideline.
Thanks, Lindsay, and welcome back, everyone. Hope you were able to get a quick snack. So this guideline, as we heard, was published in June. I'm really excited to have today's webinar and have so many of you with us. We want for you to read this guideline, really understand all of the good practice and recommendation statements to really be able then to kickstart your implementation. We know that reading a guideline in and of itself does not create a practice change, that we need active processes. And so what I want to focus on is really these early steps as far as supporting implementation, and talk a little bit about developing some compelling messages about this BPG, talk about why we want to implement it and how this guideline can really help us in implementing the guideline. To think about integrating principles of equity into those implementation strategies, talk a little bit about a change team for this BPG and who needs to be a part of that change team, and then how we can build some capacity in guideline implementation overall. So as far as developing compelling messages, I want you really to think about the impact and implementability of this guideline. So we'll focus first on impact and then turn our attention to implementability. When we think about the impact, it's really what are the benefits of this guideline? Why should we implement this guideline? Ultimately, how is it going to help to improve health outcomes? And then second, we'll talk about implementability. This is really contextual, but it's really how much can we easily adopt, integrate these best practice and good practice statements. So first about impact. And for impact, as we've seen, and I'll highlight as well, we can glean a lot of this from the guideline itself, from the evidence, and from the background section. But we can also use stories. Storytelling, narratives can be really powerful as another way of communicating the meaning, the value add of implementing this best practice guideline. And we've heard Judy's story, a very powerful one, why for her and her family, the transitions in care and services is so valuable, and why having best practices really can add to good person-centered care and good outcomes. What we know strategically, as far as conveying the meaning, the why we should adopt this guideline, is that we can do that both by looking at the evidence in the guideline, as well as hearing those stories, hearing the person's voice and their family to really better understand why this guideline and its impact can be so valuable. So I'll turn it back to Lindsay just to introduce our next speaker, who's also going to share another story about the impact of transitions in care and services.
Thank you so much, Catherine, for that introduction. And we're going to pass it over to Chantel Antone now, who's going to share with us from her experience. And again, Chantel is the Senior Director of the Office of Inclusion and Social Accountability for Indigenous Health with London Health Sciences Centre. So welcome, Chantel.
Oh, yeah. Can you hear me?
Yeah, we can hear you well. Thank you so much.
Okay, good. Yeah, thank you, Lindsay. Good afternoon, everyone. So I'm coming to you today from the First Nation community called Oneida Nation of the Thames. That is my home community. I'm a First Nations woman, and my background has been nursing for the past, I think I'm going on to my 12th year. And so when we think about navigation and the good practice statement around navigating communities and people and care partners, and then thinking about the title of this work as a guide, it's really just to help us navigate systems, but it also helps us to consider and think about, with the equity lens around what are some of the things that we might not understand, or what are some of the things that we need more learning on. And that's where we're really connecting the head and the heart around what's really impacting this family or this person or their caregiver at any given moment. And so when we're thinking about navigation and guides, like a guideline, we're really thinking about that person-centered care. And I've had to do a lot of self-reflecting on some of the language that we use in healthcare. And really we need to start to like really break things down just to their simplest form. So what is it that could make your make today or this moment better? Or and I share an example. I went to a restaurant, and one of the waitresses had shared with me about her experience, and she said she asked us at the table, and she said, is there anything else that I could do to make this experience better for you? And right in that moment, I kind of almost felt this aha moment, and I thought, this is where in healthcare we can just use 5-6 more words in our work to connect us with our with our minds and our bodies and our spirits about people who have been impacted by the system in different ways that that many of us may not be aware of. And so I think just using some self-reflective practice and thinking about things that might not have happened in our own lives, and then just asking asking that sentence, what can I do to make this experience better? And that's really what navigation is really about at its core. It really is about and sometimes it's not even those things around booking appointments and that sort of thing. It's really just being there for some folks who just know that they have someone to call to say, I'm having a really difficult time. I don't understand what's next or what I need to do. And I was really inspired by the story that was shared at the beginning around being discharged from from hospital and then being sent home and needing to, and I think she described it as her husband's look of fear on his face. And so in the communities that I've worked with in the First Nation, Inuit, and Métis communities that I've navigated for the past 10 years, I would say that was a pretty good explanation about what I've experienced working with and working beside Indigenous patients and their families around not really having a good grasp of the medical system. And in fact, I think that's just the reality of it. It doesn't mean that that's a negative thing. It just means that healthcare is complex. And with the complexities of healthcare, amplified with the complexities of Indigenous health, which really stem from policies that have impacted our communities in ways that have been detrimental to our health. It's a real mix of complexities and interwoven factors that many of us may not be aware of. So I do believe that, I really like that message on the screen there about creating meaning by engaging with others, being with them, working for them. And a lot of it is just, I was in an event last night with the engagement with First Nation communities across Southwestern Ontario, and they wanted to know what one of the questions was, what does patient-centered care mean to you? What does safe care mean to you? And one of the responses that was shared in the group was, if you smile at me and you look at me. And the person who was explaining that was one of the facilitators, and she became quite emotional about that because she thought that culturally responsive care was a mix of training and understanding people's traditional medicinal practices, when in fact it was just being with those people in that moment, giving them a look of kindness, maybe offering or even asking, is it okay if I touch your hand or touch your shoulder, those sorts of things. And so when we think about, engaging with and connecting our head and our heart, it really just goes back to basic humanity and just basic interactions with humans on how would we like to be treated, how would we treat our parent, how would we treat our daughter, and how would we treat our child. So, navigating people for the past 10 years, I've had that lens, and it's really been quite the experience in molding and shaping where we're going into the future for opportunities like this best practice guideline. As a First Nation woman, to be a part of this team, I have to give RNAO, a big kudos for that, and the women and the team members here to, to make that effort to reach out to communities to say, we want to hear your voice, and really looking around and saying, who isn't at the table and who is. And so with that, I'll end there, and I just want to say that I appreciate this opportunity and the privilege to be a part of this group and to be able to share some insight into Indigenous health and navigating the system. Thank you.
Thanks, Chantel, for sharing that, and just the importance of humanizing care, hearing that person's voice and respecting what's important to them, and so important in transitions in care and services. So on the next few slides, I've pulled from the background just some of the impact key points that you might find as well, that you might share again as you begin to think about some of the key messages regarding this guideline, trying to create some meaning of what does it mean and what's it going to mean for us. And so understanding that transition in care and services is a significant point in healthcare provision. It involves a lot of healthcare providers and teams and settings, so involves lots of individuals. And that this is something that occurs, it can occur once, but very often, especially in complex care situations, multiple times. So it's a situation in which having best practices, having that consistency in practice can be so valuable for us as health professionals, and involves not only a transfer of information, but also those care needs. What's most important to that individual, so we continue to provide person-centered care throughout care transitions. We also can focus again on the person and their families and understanding care transitions as a major life event. We've talked about that this can be represented in a number of ways, including moving from a home to a long-term care home, or from hospital to home with a life-changing health status, and how important that is to that individual and their needs at that time. And that when there are gaps in care transitions, that it can represent a possible safety risk or an adverse outcome. And you can see some of those listed on the slide, like medication errors, etc. And then the resulting experience for that person and their family, feelings of frustration, of added distress, and a lack of trust then for the health providers and the broader healthcare system. And we don't want those outcomes. We want for people to continue to have a trust in their care providers and the health system. Now, in addition to defining impact qualitatively, we can also look at some numbers, some quantitative data that again reinforces why this guideline is so invaluable and its implementation to us in our settings. So we know that approximately 30% of Canadians have had a poor care coordination, where there has been a gap either in information or in conflicting information being shared. And again, that can cause safety concerns and just frustration. The rest of this data applies to unplanned hospital readmissions. So about 200,000 Canadians annually will have an unplanned hospital readmission. Again, that's an example of a care transition. 1 in 11 will leave a hospital and be readmitted within 30 days of a care transition, especially those with chronic illnesses. Very expensive. This is a huge financial burden, with $2.3 billion for unplanned hospital readmissions. And this last point that I think really we need to take away is that 25% of unplanned hospital readmissions are preventable. And again, if we can apply best practices in care transitions, we can help to get that number down. So we've talked about the impact of the guideline. We also need to consider, can we implement it in our setting? This is highly contextual, but we can look to the guideline and the many resources that are included to be able to support achieving the implementation of this guideline. So I want to highlight some of that content for you. And again, we've heard from our co-chairs, thanks to them again, a review of the good practice statements and recommendation statements. So for this first one, for example, and I'm just going to highlight 3 of the good practice statements and some of the content in the guideline that can help us getting started with thinking about implementation, really turning these statements into best practices in our organization. So this one that focuses on collaborating with the person and their support network. So in the guideline, you will find, I'm not thinking you're going to read this right now, but you will find then implementation tips, and they've come from our expert panel. And again, our expert panel are made up of senior leaders, like our co-chairs, those working in the front line, as well as individuals like Judy and Chantel who bring that lived experience. So a wealth of expertise, and these implementation tips really get us starting thinking about actually making this practice change. So look for those in each of the recommendations and good practice statements. In addition, there are resources in the appendices. So in this example, again, relevant to this specific recommendation or good practice statement is a patient-oriented discharge summary. And while you may or may not choose to use this, it can give you some insights into the kind of questions or components to include in a discharge summary. Something that, again, helps us to start thinking about operationalizing this practice change and really be as fulsome as comprehensive in the practice change. And then again, in the supporting resources, you will find some additional resources that can help you to think more about implementing this best practice or good practice statement. If we look at the next one, again, focused on interprofessional collaboration. Again, we've recognized that in this guideline, it very often involves a number of care providers and teams and settings. So lots of interprofessional collaboration components. So again, you will find implementation tips from the expert panel, as well as implementation tips from the evidence. Again, that can help us with thinking about making this practice change. And again, in Appendix H, you will find an example of a care transition plan. Again, you may or may not choose to use this, and you could look at this source to see in its copyright whether you can just adopt this care plan or and/or what other requirements are needed. But again, it helps us to start thinking about what does a good transition care plan look like? What are all the components? So again, have a look at Appendix H if you're implementing this good practice statement for some ideas on that. And similarly, in the supporting resources, you will find a resource that was developed in the US on care transitions from hospital to home. And this is an ideal discharge planning implementation handbook. Again, it can help us just with some ideas about how to integrate and adopt these good practice statements. And then finally, a good practice statement 4.0 focuses on the review of medication history and what is best practices in this area. And again, for this one, you'll find more implementation tips from our expert panel. Again, thanks to them for taking the time really to think about the real life interpretation of these statements and how they can best be adopted into clinical settings. If you look on Appendix Appendix I and J, you'll also find some additional resources that will help with the adoption of this good practice statement and the review of medication history. And also there's a supporting resource that came from CPSI on safe practices in this area. So again, lots of great resources in the guideline, in the discussion of evidence, and in the appendices and supporting resources that can help you with the implementation and just really thinking about how to make these practice changes. Lots of great resources. And for the appendices, these resources have not had the same systematic review and the grade methodology applied to them, but still have gone through a vetting process to ensure that they are high quality resources. Now, we've heard from our expert panels, and also Chantal mentioned this as well, the importance of having a lens of equity as we consider implementing these good practice statements and recommendations. And so we need to think about how can we have these principles of equity in order to achieve best practices. And this includes then, it's really understanding the person's life, includes recognizing social determinants of health and how these two can impact health outcomes in care transitions. And for this, we can think about it at the system or micro level, at the meso or organizational level, and at the micro level. at the point of care. So at the macro level, so if we're wanting to advocate, for example, for more primary care services in our area, so that when we transfer or we transition someone from hospital, for example, to primary care, do they have a primary care provider? Do they have the services that they need in our region? This often involves changes in policy and needing to do advocacy work. It's a reminder that RNAO, we have our action alerts, as well as opportunities like Take Your MPP to Work, as ways then of advocating for equitable practices, including those that involve care transitions. We can also think about it at the point of care at the micro and meso levels. And so some considerations could be that we have a current list of relevant resources in our setting, things like support groups or respite care, if that's applicable, that helps then to support access to these services. Also having accessible health education that's written in plain languages, that includes visuals that can help to support understanding, and having them available online or print is another way of advancing equitable care transitions. Do we have on-site and written translation supports, a way so that all languages are understood, can be understood, and ways then that those discharge or care transitions information then can be understood by the person and their family? Do we have in our organizations training and integration of care principles that embrace principles of care, cultural safety, anti-racism, and equity? And finally, having safe and effective staffing workloads. While not directly related to care transitions best practices, we need to have the time to be able to conduct a medication history or work effectively across teams in order to, and settings, in order to have effective care transitions. So considering all of these additional components to advance equity to have best outcomes. A reminder that we have our foundational implementation resource called our Leading Change Toolkit available online. And this works for this guideline and all of our guidelines to help change agents and change teams to make lasting improvements in healthcare. And when we think about making practice changes, including transitions in care and services, that we want to think about people first and then processes. And when we think about engaging people, our stakeholders, our change teams, all the individuals that are going to be involved in a practice change, our social movement action framework can give you good insight into how to take that process, in which then we engage people as leaders in their change process and create change. In addition, then we think about process, and that's our knowledge to action framework, and that's outlined in the 7 action cycle phases. And that when we combine these 2 approaches, engaging people as change agents using grassroots approaches and adopting the knowledge to action cycle phases, it can give us a comprehensive approach to change. Oh, sorry, my apologies, jumped in. Now we've mentioned that part of doing good implementation includes having a change team. So these are individuals who are going to be involved in the leading and guiding of the adoption and integration of this BPG. And so for this guideline especially, we always want to think about having persons with lived experience. I think this is especially important for this guideline. So whether it's the person, their family, their support network, advocates, really, really important in the adoption of this guideline. So a reminder that in the Leading Change Toolkit, we have a section on engaging persons with lived experience in a change initiative and how to do that effectively. Another resource on is your change team ready to engage persons with lived experience. So if you have not ever had a person as part of your change team, how to do that and do that effectively, and then some considerations for getting started. All those resources available online. Now, we did want to ask you, as part of implementation, we know that conducting a gap analysis is one of the first steps often that a change team will do. And so if we think about a review of medication history, we've heard a little bit more about this good practice statement, just wondering if you can put in the chat box for us, and Christine is going to follow up with this in regards to evaluation. Just if you can indicate whether this good practice statement in your setting, is it met in that all of the components that we see described in the statement, all of those are currently being adopted in your setting? Is it partially met where most of these components have been implemented, or is it unmet and this would be a change in practice, and there would be lots of components to be changed or modified? So if you just put in the chat box whether it's met, partially met, or unmet, and for those of you where it's met or partially met, maybe indicate what parts have already been implemented. Then I can see some people are saying that it's partially met. So that's great. It's indicating that there's some small pieces of work to be done, and that's a great starting point for implementation of this guideline. Thanks, everyone. So just a reminder that at RNAO, we provide lots of opportunity to strengthen capacity in BPG implementation for this guideline and for others. And that includes our programs of our Advanced Clinical Practice Fellowship Program. We have our Champions Network, just had part 2 of our monthly Champions webinar or workshop series. We're really excited about our upcoming symposium. That will be another opportunity to talk about guideline implementation, as well as starting in October, our Clinical BPG Institute. So lots of ways in which to learn more about guideline implementation, which is often a complex process, but really can be best started with reading the guideline and really seeing all of what the tools that are in this guideline that can help with that. So I'll pause there to see if there's any questions before handing it over to Christina.
All right, thank you, everybody. So my name is Christina Medeiros, and I'm the Senior Manager of Evaluation and Monitoring at the RNAO. And a little bit about the evaluation monitoring chart. It's actually located in the BPG on page 17. And what it looks like is that we have a bit of a title page, and really gives a bit of a description of our process and outcome indicators that are developed based upon the Donna median model. So our process indicators measure the interventions that are done to or for persons receiving care. Thank you, Glynis. And are aligned with our good practice statements and recommendations in the BPG. And our outcome indicators are aligned with the outcomes of the research questions of the BPG, and really measure the outcomes of the interventions that are being implemented. And this is what thank you, Susan, our indicator charts look like. So we have for our process indicators, a recommendation or good practice statement that it's aligned with, as well as a process indicator, operational definition, as well as numerator denominator. And the alignment and our outcome indicators look very similar in that there's our outcome indicators and our alignment with the indicators and data repositories and instruments. So a little bit about our indicator development process. It's a 6-step process, and just a little bit about how we really engage with our expert panel as well as our stakeholders in terms of providing feedback in our indicator development. Once we've selected our guideline section, when we have our recommendations and good practice statements, we really ask for feedback from our expert panel. We align our indicators with external data repositories and instruments, which I'll go through in the next slide, and really send out our indicators for both expert panel validation, as well as our stakeholder validation. And we thank both so very much for all of your really pertinent feedback that really made these indicators what they are. And then afterwards, we are currently in the midst of developing our data dictionary, as well as building these indicators within our NQuire data system for our BPSOs, our best practice pilot organizations, and our best practice pilot organization, Ontario Health Teams. And then we also conduct data quality assessments that inform the next edition of BPGs and the corresponding indicators. As I mentioned before, as part of our indicator development process, we link our indicators to external data repositories, really to adhere to a collect once, report multiple times principle. And we align these indicators with global databases like the WHO and OECD, as well as other international databases, our national databases, CAI, PHAC, Accreditation Canada, Healthcare Excellence Canada, Statistics Canada, as well as our regional databases, Ontario Health, Public Health Ontario, ICES, and BORN. And as Catherine mentioned, for this little explanation and how we would go about evaluating, I wanted to use a good practice statement, as I think we've conducted a bit of a gap analysis in the chat box for good practice statement 4.0, which was focused on best possible medication history, as well as our medication reconciliation at all transition points. So any good evaluation effort really starts with an evaluation team. And so our BPG implementation lead is at the center of the success of being able to effectively evaluate the impact of BPG implementation. And it's really important to engage persons with, some sort of clinical expertise and leadership and experience who really know how these changes will affect care processes. So engaging frontline staff like nurses and other interprofessional team members and gathering their feedback about how this would affect their care processes and impact on persons who are receiving care, as they're the ones really implementing these changes and probably collecting the data. It's also important to engage senior management or a project sponsor, someone with executive authority that can help champion this quality improvement project and help scale these implementation efforts as well. Also helpful to have support for people with technical expertise who understand quality improvement processes, how health information technology systems can really work together, and other decision support specialists. And of course, we need to include individuals who exhibit day-to-day leadership, such as our professional practice leads, to ensure the completion of tasks such as data collection, analysis, and change implementation. And of course, our persons with lived experience as well. So in order to select indicators, it's really important to define your measurements. And so after conducting that gap analysis or opportunity analysis, next step is really to select indicators related to process outcomes and structures. And so when selecting your indicators, you really want to consider the feasibility of data collection and organizational priorities. So we really want to think about the resources we have to collect data on this indicator. Who can help you with this project and where you can get this type of data. And whenever possible, choosing measures that of data that you're already collecting. So really understanding that collect once and report multiple times principle. And sometimes you may have to create new measures, but I think we'll be focusing on the indicators present on the evaluation and monitoring chart in the BPG. And also selecting indicators that do align with the good practicing or recommendation that you're implementing. And also considering the level of implementation. So will the guideline recommendation or good practice statement be implemented in specific areas or organizations within OHT? Or will it be implemented across an OHT, for instance, or throughout your organization? So some things to consider. And as noted, as I mentioned before, this was just a bit of a view of the outcome indicator portion of our E&M chart and really adhering to that collect once, report multiple times principle. So next, after you've gone through your selection of indicators, you really want to also create an evaluation plan. It really sets out the details of your evaluation and reflects what needs to be evaluated, how and when. And it's like a roadmap, really, as the evaluation plan really shows the route traveled or steps taken to reach a certain destination. And it really identifies both the processes used and outcomes to be achieved. And it identifies really how success will be measured. And so evaluation plans are not usually created in one sitting. People involved in creating this project initially brainstorm and map out a preliminary evaluation plan, and others involved, like staff, should be consulted to really refine this plan. So here's an example of a logic model which is commonly used for evaluation. So given the gap analysis, the focus was on implementing the good practice statement 4.0, which focuses on the best possible medication history and medication reconciliation. And for this logic model, we're really focusing on the medication reconciliation. And here you see in blue are inputs. And those are the resources that you need for a project. So, perhaps a clinical educator, funding, of course, professional practice lead, a valid medication reconciliation tool, of course, as well. And next are the activities in orange. And those are really thinking about the activities that need to be carried out as part of the project. Education workshops, perhaps, and how to use this medication reconciliation tool. Maybe education pocket cards for health professionals could be created that they can carry along and remind them of conducting a medication reconciliation. And perhaps an update to the documentation to really include this medication reconciliation tool. And outputs are the products that are produced from these activities. And they usually provide a numeric value or attributing percentage, like the number of nurses trained or number of health professionals trained or number of workshops conducted. And then you have your outcomes, which can be short-term or long-term, and they're really associated with changes in knowledge, awareness, behaviors, and skills. So here we can see increased awareness and knowledge and increased use of the medication reconciliation tool. And long-term outcomes perhaps can be, fewer emergency department visits. You can also see the corresponding process indicators from our E&M chart, percentage of persons who had a medication reconciliation completed at all transition points during the measurement period, and the outcome, the long-term outcome, perhaps, percentage of newly publicly funded home care clients of all ages who had an unplanned emergency department visit in 30 days after leaving hospital. And both are selected in red. And so we know knowledge is also a really critical, important element in understanding whether clinicians understand, accept, adhere, and apply to evidence-based practice recommendations and good practice statements. So monitoring knowledge really helps to understand these questions. Are these recommendations or good practices being implemented? Is the implementation intervention working? So during the implementation phase, you can monitor knowledge use to provide insights on the rollout of implementation activities and changes. And really looking at two types of knowledge uses, perhaps, conceptual knowledge use really is a knowledge that describes a healthcare professional's understanding and internalization of knowledge and information. And you can measure this by administering a knowledge test before or after an education session on perhaps doing these medication reconciliations. And instrumental knowledge is really the knowledge that has been applied in practice and resulted in influencing behaviors or actions. And you can really measure this by perhaps doing a chart audit to really see if these medication reconciliations have been performed at all transition points. And also, once you get all this data, it's really important to share this quality improvement data to really understand the impact of evidence-based practices on outcomes. Really engage your frontline workers, as Catherine was talking about, and others in making this change and keeping the momentum going, and really promoting innovation and spreading these best practices and really continuing to improve the care for the persons that you provide care to. And you can really tell a story about how this is going in terms of, perhaps an evidence booster or displaying this in different types of graphs, whether they're bar graphs or line graphs, and really sharing this data with important members of your team and perhaps the persons that are receiving care to really show the impact of these best practices that you're implementing and really celebrate your successes. And thank you. I think I might hand it over to, I believe, Kristen.
Thanks, Christina. Maybe just before we go on to there, I see one question in the chat box related to evaluation from Jennifer, and I wondered if you might be able to answer that one. It says, in the create an evaluation plan slide, does inputs equal structural indicators and outputs equal process indicators? Thanks for clarifying.
Yeah, so for this indicator, we don't really have structural indicators, but I think that you're correct, Jennifer, in terms of those inputs, really looking at whether you do have that type of structure in place, and perhaps do you have those educational materials or professional practice leads and those tools available. So yeah, thank you for pointing that out. I appreciate it.
Much, Christina. So thank you so much, Catherine and Christina, for sharing with us about implementation and evaluation of this guideline to get us thinking next steps in terms of this guideline. And really, really exciting to be thinking this way. So I'm going to pass it over to my colleague, Kristen Campbell, who's going to share much more about one more webinar that's going to be coming up on August 14th.
Yeah, great. Thanks, Lindsay. So thanks, everyone. What a great introduction to this exciting new guideline. And we just want to let you know about another opportunity. I think we've heard very clearly how important this guideline is to an integrated systems of care. I think Judy provided an excellent example of this early on during the webinar. So on August 14th from 2 to 4 p.m., we're going to take a deeper dive and a real strong focus on this guideline to support the success of Ontario health teams. So new guidance for OHTs, transitions in care and services, best practice guideline. And I'll put the link in the chat, but we're hoping you can join us. And this is open to anyone who belongs to Ontario Health Team or is involved in this work. We'd be more than happy to have you join us on August 14th. So thank you. I think Anu just put it in the chat for us, so thank you.
Fantastic. Thank you so much, Kristen. Okay, so we are getting close to the end of today's presentation, and we wanted to share, though, there are emails listed here, so you can contact us if you do have further questions. So there is a general contact us website that you can go to, and that will direct your inquiry to the most appropriate person. But you can also contact myself, Lindsay Howlett, Senior Manager with Guideline Development and Research, Catherine Wallace with their implementation, and Christina Medeiros with evaluation and monitoring too. Reminders as well that you can use the QR code there. You just pull up your phone, there's the camera on your phone, and you can scan this image and it will bring us to the page where you can download a copy of the best practice guideline as well. And the URL is also here too. We do have some time for questions as well, but before we go to that, we just want to say again, thank you to the Government of Ontario. This work is funded by the Government of Ontario, and all work produced by RNAO is editorial independent from its funding source.